international fellow has done win an international fellowship from Society of Maternal Fetal Medicine, and he has grant from Department of Biotechnology, Government of India, Human Development and Disease Biology, and he has award from Pani Sheshadri Memorial Oration and gold medal for best post-graduation dissertation in JIPMA. He has publication in various national and international journals. And Dr. Sasireka Madam, who is Associate Professor in JIPMA, short-term fellowship in obstetric medicine. Her areas of interest are obstetric medicine and high-risk pregnancies, publications, more than 25 national and international journals, and working on, Madam is currently working on preeclampsia, auditing cesarean section using Robson's classification system. Over to you, sir and ma'am. The presenters, please introduce yourself and share your PowerPoint.
Good afternoon, everyone.
As an organizing chairperson, I welcome Dr. Manikandan and Dr. Sasireka for this program. Thank you for accepting my invite and coming to the program.
Thank you, madam. Sasi, hi.
Thank you.
You have to unmute.
Sorry. Good afternoon, ma'am. Thanks for the reminder.
Okay.
Okay. Hi, Sasi. How are you?
Fine. Yeah, it's my great opportunity to share this platform with you. So after a long time.
Yeah.
Okay, happy to be there here. Yeah.
It's been quite some time. So hello, Shruti, Manoj, Aishwarya.
Good afternoon, sir.
Hi.
I'm Aishwarya. Myself, Shruti.
And I'm Dr. Manoj, sir.
Aishwarya, please share your screen.
Yes, ma'am.
Make it a slide.
Shall we start, ma'am?
Yes, go ahead.
Good afternoon, everyone. Our presentation is on fetal growth restriction. Myself, Aishwarya. With me are Dr. Shruti and Dr. Manoj. Our patient, Mrs. X, 29 years of age, hailing from Villupuram. She was educated up to 12th standard, a homemaker by professor. Homemaker. Her husband is 35 years of age. He is educated up to 9th standard and a textile worker. Their per capita income is 500 per annum and belongs to lower class of modified BG Prasad classification. Their nearest health facility is Kandachipuram PHC, which is at a distance of 10 minutes from their house, and Jipmer is at a distance of 4 hours by bus. She is a second gravida, para-1 with 1 living issue at 9 months of pregnancy. She has regular cycles. She is sure of her dates, and there is no history of oral contraceptive use in the past 3 months. Based on that, her LMP being 10th June 2021, her estimated date of delivery is calculated to be on 17th March 2022, and her period of gestation is 36 plus 6 weeks. The dates were verified by the scan report, which showed a gestation corresponding to 16 weeks. And since the dates were corresponding, the period of gestation is assigned from her last menstrual period. She is booked at Mugayur PHC, and this is her first visit to Jipmer in this pregnancy. She was referred with chief complaints of reduced growth of the baby and less Liker level found in an ultrasound examination. History of present illness. She was found to have less Liker and reduced growth of the baby on ultrasound and at 34 weeks of gestation. She is currently pursuing fetal movements well. There is no history of bleeding or PV or leaking PV. There were no high BP recordings in her. She has no history of any chronic medical illnesses, including hypertension, diabetes, or immunological conditions and renal disease. There is no history of any medical intake other than hematinics. Her bowel and bladder habits are unaltered. Coming to history of present pregnancy, first trimester, this was a spontaneous conception. However, she had no antenatal visits in the first 3 months. She has not taken periconceptional folate, dating scan, or first trimester screening was not done for her. She was detected to be pregnant only at the 3rd month of gestation by a urine pregnancy test at home. And later she got an ultrasound done at 16 weeks of gestation, which was told as normal to her. There is no history of excessive vomiting, urinary complaints, bleeding PV, or radiation exposure or fever with rashes in the first trimester. History of present pregnancy, 2nd trimester. 3 antenatal visits were there in the 2nd trimester. She felt quickening at the 5th month. She received 1 dose of DT at the 5th month. Anomaly scan was done at 20 weeks and there were no gross malformations. She also underwent the screening for diabetes with DIPSI test at the 5th month. It was also told as normal. There were no high BP recordings in the second trimester, no history of bleeding or leaking per vaginum. Baseline blood investigations were normal. Iron and calcium were started from the 4th month of gestation and she was compliant to it throughout the pregnancy. There is no other medicine intake other than hematinics. History of present pregnancy in the 3rd trimester, there were 2 antenatal visits. On January 10th, she had a HbA of 7 gram per deciliter, for which she received 4 doses of iron sucrose, and a repeat hemoglobin was 10 gram per deciliter. At 34 weeks, during examination, her fundal height was found as not corresponding to the gestational age. She was advised an ultrasound, which showed a Liker of 5 and an estimated fetal weight of 2 kg. And due to low Liker and reduced growth of the baby, she was referred to JIPMER. History of present pregnancy in the 3rd trimester, she is perceiving fetal movements well. There is no leaking or bleeding per vaginum, no high BP recordings or raised blood sugars. There are no urinary complaints.
Aishwarya, in a hurry?
No, sir. Sorry, sir.
Go ahead.
Menstrual history. She attained menarche at 15 years. She had regular cycles. Flow was normal. There was no dysmenorrhea. There is no history of use of oral contraceptive pills or any other method of contraception. Marital history. She is married for 5 years, a non-consanguineous marriage. Past obstetric history. Her first child was conceived 2.5 years after marriage. It was a spontaneous conception. She was not evaluated for infertility or nor received any treatment. Currently, the child is 2.5 years old. She was booked and immunized in the first pregnancy. However, in her first pregnancy also, at 38 weeks of gestation, she was told to have fetal growth restriction and she was referred to JIPMER for the same. At term, she was admitted in JIPMER. There were no high BP recordings or high sugars in the first pregnancy. At 38 weeks, she was induced in view of fetal growth restriction and she delivered a male baby, 2 kg birth weight vaginally. The baby cried at birth, but was shifted to NICU in view of imperforate anus. The baby underwent surgery on day 7 and is currently doing well. She breastfed the baby exclusively for 6 months and continued breastfeeding along with complementary feeding until 1.5 years. There is no history of postpartum IUCD use or any other method of contraception. Past history, no, she has no history of diabetes, hypertension, jaundice, epilepsy, TB, heart disease, or any other medical illness in the past. There were no surgeries in the past. Personal history, her sleep and appetite is normal. There is no history of psychiatric illness nor substance abuse. Diet history, she takes a mixed diet. Her pre-pregnancy weight was 40 kg. Her current weight is 44 kg. Her weight gain is 4 kgs in pregnancy. Her calorie requirement is 2,250 kcal per day. She consumes 1,750 kcal per day. There's a deficit of 500 kilocalories. That's around 22% in calories. And in proteins, there's a deficit of 12 grams, which is around 27%. Family history. There is no history of congenital anomalies or multiple gestations in the family. No history of chronic illnesses in the family. No history of TB in the family. Summary. Mrs. X, 29 years. Gravida 2 with second gravida with 1 living issue at 36 plus 6 weeks of gestation. She was admitted with low Liker and reduced growth of the baby. She is currently perceiving fetal movements well. There is no complaints of bleeding or leaking per vaginum, no high BP recordings or no chronic illness. There is history of anemia for which she has received iron sucrose injections and the repeat HB is reported as 10. Her weight gain in the pregnancy is 4 kilograms. There is a definition, it is poor weight gain in this pregnancy. There is a deficit of 22% in calories and 27% in proteins. There is history of FGR, fetal growth restriction in the first pregnancy for which she was induced and delivered a 2 kg baby vaginally previously. The first child also has a history of imperforate anus which was successfully operated and the child is doing well currently. Examination. The patient is comfortable at rest, averagely built and nourished. Height is 153 centimeters, weight is 44 kg. Current BMI is 18.7 kilogram per meter square. Pre-pregnancy weight was 40 and the pre-pregnancy BMI is 17.08, which comes as underweight. Weight gain in pregnancy is 4 kg. She is afebrile to touch, mild pallor present, no icterus, cyanosis, clubbing, lymphadenopathy or edema. Her BP was 130 over 80 millimeters of mercury in the right arm in sitting position. Pulse rate was 80 per minute regular. Systemic examination of cardiovascular system and respiratory system was normal. Breast and thyroid were normal. Spine and gait were normal. On obstetric examination inspection, the abdomen was uniformly distended. The flanks were not full. All quadrants were moving equally with respiration. The umbilicus was normal and central in position. Linea nigra and stria gravidarum were seen. Hernial orifices were free. Palpation, the fundal height corresponded to 32 weeks and symphysia fundal height was 32 centimeters. The flanks were not full. Fundal grip showed a broad, soft, non-ballotable part suggestive of fetal breech. The right lateral grip gave a uniform curved resistance suggestive of the fetal back. Left lateral grip, multiple novi projections were felt suggestive of fetal limbs. In the first pelvic grip, hard, globular, mobile, ballotable part suggestive of the fetal head, 5/5 palpable was felt. In the second pelvic grip, a well-flexed head was felt, vertex presentation and unengaged. The Likert appeared average and the estimated fetal weight by clinical examination is around 2 kgs. On auscultation, the fetal heart was here heard on the right spino-umbilical line, 140 per minute was regular. The estimated fetal weight by Johnson's formula came as 3,100 grams. Diagnosis, Mrs. X, 29 years of age, 36 plus 6 weeks of gestation, a singleton pregnancy with suspected fetal growth restriction, average Likert, vertex presentation, not in labor.
Okay, is there one more presentation? One more case?
No, sir, only this case.
Okay. So what happens to Manoj and Shruti?
Discussion.
Oh, okay. So we have 4 discussants and 1 presenter. Just joking. Okay, Shashi, can you start?
Aishwarya,
Yes, sir.
whenever we present FGR, 2 important things we have to tell in the history. As you already mentioned, one is the estimation of gestational age. That's the most important single step in arriving at a diagnosis, that you have pointed out clearly that there is a clinical examination as history as well as a ultrasound examination, but then you finally arrived at gestational age based on some assessment. Second important thing is weight gain. This is a simple thing which we may not routinely see in day-to-day practice, but it's a lot of importance carries on it, because fetal growth restriction is not a static event. It's going to be an ongoing event. There are some temporary or measures which if you correct that, it will get corrected. So I have one question on you. Your history is very complete. I mean, from my perspective, we will ask Dr. Mani's opinion later. So what is the role of daily fetal movement count in such situations?
We have to explain to the mother to do daily fetal monitoring count when there is when there is fetal growth restriction. It is one of the sensitive parameters to know the fetal status. Like a mother, when the daily fetal monitoring count is reduced, it indicates as some sort of fetal compromise, and we have to evaluate it further.
Yeah, though we have tools to recognize the fetal surveillance, but we have to tell them about fetal movement count. And one more question: symphysia fundal height, right? You measured 32 centimeter. So
Yes,
what is the role of symphysia fundal height in evaluating FGR?
Symphysia fundal height, in screening for FGR, it is an important tool, ma'am, especially in peripheral settings where ultrasound monitoring is not available. So where we plot gravidograms, we can the symphysia fundal height can be plotted against a gestational week, and we can see for the growth of the baby, and any fold we can see for the
late onset FGR also can be detected.
Manoj, louder please.
It can be early onset and late FGR can also be detected in the.
Okay, you mean differentiated?
That
The symphysia fundal height is less than 4 centimeter. Is a marker for fetal growth restriction according to the gestational age.
it is a screening tool mainly in low risk pregnancies. High risk pregnancy have to undergo ultrasound assessment. In a low risk pregnancies, especially in a low risk setting, it's definitely useful. So what are the situations where we cannot use symphysia fundal height? After that, Dr. Mani will take over.
In gestation.
twin gestations,
Okay,
obesity,
obesity.
Polyhydramnios.
polyhydramnios.
Okay.
And then
Okay.
the patient might have
Wrong
intra-abdominal tumors, pelvic tumors, which might push up
Okay.
the
Wrong dates.
Okay. Okay. So we'll
Okay,
look
so
forward to you.
Yeah, so the fetal movements was highlighted by Sashi, and it's a very important thing. I will just add one comment on that. Whatever may be the results of your evaluation, fetal evaluation, like a CTG, Doppler, ultrasound Leica, whatever. Of course, we will come back to this later. But fetal movements perceived by the mother, and if she's sure, will supersede everything. Okay.
Yes, sir.
Okay, so let's go back in the presentation towards the history part. Aishwarya, go back.
Yes, sir. Yes, sir.
Keep going back. Yeah, go back. Okay, the next one, next slide. So the first slide, the socioeconomic status and the way she behaved as an obstetric performer in the last pregnancy and her BMI. So these set up the stage that she is not going to deliver a big baby anyway. She's going to be delivering a baby which is on the lower centiles. Is that clear?
Yes, sir. Yes, sir.
Okay. So one of our goals in evaluating this pregnancy is to differentiate SGA from FGR. I understood that Aishwarya used the word FGR quite loosely. For example, she referred the previous outcome as FGR. We will find out how they are different later, but at present, use the term SGA if you only have the information that the baby was small in size. Okay?
Yes, sir.
Okay. Now, you said that the dates were verified by 16-week scan, and then the POG was assigned from LMP. This is a very good statement, but let's go into the details here. What do you mean by the dates verified by 16-week scan? Manoj, okay, or one of you.
Depending on the gestational age, sir, like in first trimester, like if you are taking a scan of 9 weeks, the discrepancy of 5 days are accepted for that one. From 9 to 14 weeks, the discrepancy of 7 days will be accepted from that one. And from 16 to 22 weeks, a discrepancy of 10 days will be accepted in that one. So
what happens between 14 and 16?
14 and 16, if all the four parameters are seen, sir, a discrepancy of 7 days is accepted. If AC, FL, BPD and HC is seen.
Okay, let's go back and clarify. There seems to be some confusion. So up to 14 weeks, what is the ultrasound parameter that you will take to compare with the LMP based gestational age?
CRL.
So there should not be any doubt. And if it's more than 7 weeks, then certainly you have to change it, even if the mother reports a regular cycle. Clear?
Yes, sir.
Now, up to 9 weeks, for example, but not like 6 weeks and all, you should not change at all. So between 7 and 9 weeks, if the CRL is differing from the LMP by more than 4 days, then you might change it. Okay. More than 7 days, of course, you have to change it. But less than now, in both these cases, you must have a look at the CRL image, and that should satisfy certain conditions. It should be a mid-sagittal, a baby lying down without overflex or anything, and it should be in the mid-sagittal view. Have you seen a mid-sagittal view fetus?
Yes, sir.
Yeah, it should be. So a minimum quality CRL should be there. Then only you should assign. Okay. Okay, now let's go to the second trimester onwards, that is 14 weeks onwards. So from 14 weeks onwards, which is the parameter you will take to assign the dates?
All four should be considered after 14 weeks.
All 4 is not the right answer. Let's try again. Can't hear you, Manoj.
BPD, sir.
Not the right answer. Let's try again.
BPD, HC and FL are considered.
So you left AC, okay, it's just HC. Okay, only HC and HC in this gestation range, like the CRL, won't be much. The keyword is much affected by FGR, even if it's there. See, the danger in assigning the date is that what if already the baby is suffering IUGR? You will reassign the dates on an IUGR baby if you take all parameters. AC is very sensitive. The abdominal circumference is very sensitive. Whereas in this gestational age, a HC won't get affected that much, even though the error will be little bit more than if you do it with a CRL. Is this clear? That's why we use a larger margin. What is the margin here?
7
7
days.
7 days.
7 days? No, 7 days is for first trimester.
10 days.
It's 10 days and 14 days. If the HC differs from LMP by 10 days, okay, from 14 weeks to 18 weeks, and between 18 and 22, if it differs by 14 days. So as you see, is that the gestation age is more, the error can be more. So you have to have a larger margin. Okay. What do we call this? That is, you have to give a date based on the mode of conception, based on the LMP that is available, and based on CRL or HC. So we take three things into consideration. What can override both LMP and ultrasound, even a CRL? What can override? Is there any other information if provided that can override? Certainly not in your case. Let's say in another case.
In IVF conceptions.
In which pregnancy?
Yeah, she's coming. Good. Either in an IVF pregnancy or in an IUI pregnancy also. If you know the date of ovulation and the IUI, then that can also override, but certainly in an IVF pregnancy. You just have to be little bit clear whether they have transferred a embryo, which is day 3, or a blastocyst, which is day 5. Accordingly, you should calculate. Is it clear?
Yes.
Now, for all the obstetrics cases that you have discussed and going to be discussed, or whatever you manage, for all the obstetrics cases, all ever, whether you are going to make an obstetric decision or you are going to make a fetal medicine decision, intervention, anything, whether she's going to fly on an aeroplane, whether they're going to do a oligopoly, for all these things, what is the single most important information that is required? What is the single most information required to make obstetric decisions?
Aishwarya,
Manoj, Shruti,
you
come
have
on.
highlighted, right?
Gestation
You
LMP.
highlighted.
Excellent.
Oh,
Gestational age. So hence we are spending 10 minutes on this slide. I was very happy to see you here, right here. Period of gestation assigned. That means we have taken into account several factors and then we assign the best obstetric estimate. So hence we are spending more time here. Once we have assigned, it should never change later. Got it? The same patient you have seen at 16 weeks, let's say she has come to you, and then you find a discrepancy, and then you, let's say you assign the gestation age according to the scan, and then you say it is not 16 weeks, it is 17 weeks and 6 days. Okay. Now, when you have assigned like that, after that, it should not change at all.
Okay, sir.
Yes.
After that, any observed change is due to a change in the fetal growth. The age of the baby remains the same. We should get this point very clearly. The best obstetric estimate is assigned once, and after that, it should never be changed.
Yes, sir.
Okay, very good. So let's move on to the next. I think next I want to go to the second trimester history. All this history are very comprehensive. After a long time, I'm seeing very comprehensive. Okay, next one. So here, baseline blood investigations were normal, you have written, but go to the next slide. And then in the third trimester, suddenly she is severely anemic. No?
Yes, sir.
So what's the explanation? How much HP had fallen within 2 trimesters, I mean, between the trimesters, and why? What's the explanation?
Her HB in the second trimester, the last value is around 10, sir. And
Yes.
the repeat HB done in the third trimester had like at 28 weeks had come as 7. We have checked her compliance to iron calcium medication intake. She has been compliant, but as such, in pregnancy, the weight gain is very poor. So her nutritional status as such is poor, and with the growing pregnancy, it might have caused anemia.
Oh, do you think it will go down from 10 to 7 in a pregnancy just because of pregnancy?
Unlikely that such a huge drop will occur, sir. But there are no other history suggestive of acute blood loss or anything to cause the anemia. And
What other history might be there which can explain her poor weight gain, anemia, IUGR, low socioeconomic status? Yes, Manoj, I can't hear you. You should be loud.
Any walk infestation?
Yes, it's quite common and it will not cause any acute loss. Okay. Also, there will be error of measurements which you have to take also into account. When you saw her, did she exhibit features of chronic anemia?
no, sir, there are no signs of vitamin deficiencies.
No, sir.
Lackluster skin,
No, sir.
hair that is hypochromic? No?
No, sir.
Okay. Okay, so this blood loss is something of concern. We, as a first step, we may have to see what is going on in her stool. So stool examination may be indicated based on this. Okay. And then she responded to iron brilliantly, isn't it? So that is again an indicator that it may be an iron blood loss anemia, a hemoglobin deficiency. So once again, what can be a chronic, but nobody makes notice, mostly worm infestation in that economic group. Right. Okay, so let's now move to the next slide. Okay, perceived fetal well-being. Okay, move to the next one. Okay, yeah, this is good. Yeah, go to the next one. Okay, so okay with the history. Now go to the examination. Yeah, so yeah, okay. Here one point I have already told in the previous baby, she delivered a 2 kg baby. Did you get more information about that admission at JIPMER? Was a scan done, a Doppler done, was a diagnosis of FGR was committed in the records?
The admission records were not available, sir. But the patient told that labor was induced and it was some 10 days before her estimated date, and the baby was 2 kg. Labor was induced in view of small baby.
Small baby.
Small baby.
Okay, so we'll keep there. It was a small baby. Okay, now go. So I think it's okay. Now, Sashi, do you want to take over and ask questions about the management next step?
Did you go through the discharge summary? Because you have committed here induced in view of FGR, knowing that her low BMI and there is some entity called SGA. You have committed. So did you go through the history? I mean, discharge summary.
Her discharge summary was not available, ma'am. The patient told us a small baby actually.
Okay. Okay. Dr. Mani, you can carry on.
Yeah. Okay. So what is the difference between SGA and FGR? Or is there a difference?
Small for gestational age is when the weight for the gestational age is less than 10 centile without any either Doppler abnormalities or any oligohydramnios or anything.
Can you tell in a single can you tell in a single sentence or single word probably?
Fetal growth restriction, babies of fetal growth restriction have not achieved their genetic growth potential, whereas small for gestational age babies are constitutionally small. Their growth potential is achieved. We will differentiate with the help of the growth centiles and Doppler investigation. So when the estimated fetal weight or AC falls between the 3rd and 10th centile without Doppler abnormalities, we generally label them as SGA. SGA.
Wait. Small for gestational age. It's a simple term. It's a statistical term. If you arrange kids in a classroom in the height order and say the first 10 in the height order are shorties, that's all. Inside that, some of them may be normal, some of them may be abnormal, some may have a broken femur and hence they're short. Some of them are dwarfism. So many things can happen, isn't it? So small for gestational age is a non-specific statistical classification based on the weight compared to the gestational age. That's it. Okay. Can it inside that SGA group, can you have FGR?
Yes, sir.
Can you have constitutionally small?
Yes, sir.
Can you have abnormal babies, for example, those with a chromosomal defect or a multiple malformation?
Yes,
Yes, sir.
Because of some problem in the embryogenesis, they are still small. Can it be there?
Yes, sir.
So those are abnormal small, and some of them are normal small, and some of them are starving small. They are small because the placenta didn't give enough food for them while they were inside. Starving small. Yes?
Yes, sir.
So when you don't know what was happening, especially the first one, which also had an anomaly, it's better to put the label as SGA. But if you had access to the papers, that is the discharge summary or even the previous records, and they had documented the other criteria for FGR, then we can label it as FGR, and then that takes a different significance. Do you understand?
Yes.
Okay. Now, so SGA is a statistical non-specific term just to denote smallness in size. Smallness in size. A smallness in size with reference to the background population, whereas FGR is a pathological connotation indicating there was compromise in placental sufficiency. Okay, got it?
Okay, sir.
In her, with all the history that you have given, I am very much inclined that she's having a pre-placental issue, an issue of low socioeconomic status, not eating well, not eating correctly, not gaining adequate weight, and much more than such things, rather than an issue with the placenta. FGR is a disease of the placenta. Can you tell me one more disease of the placenta that manifests not in the fetus?
Preeclampsia, sir.
Excellent. So there is always some association. This comes, if you wait for long enough, that also comes. Okay. Association will change depending on the degree of disease in the placenta. Okay. So now what are you going to do? So we have in summary a lady who had a small baby previously that also had a single anomaly. Now she is coming to you. From 34 weeks, people outside have recognized that the baby is smallish, and she is there at 36 weeks. And you have, based on Johnson's formula, estimated 3,100 grams.
Yes, yes.
Sorry. Okay. So what are you going to do now next?
So the first step would be confirmation of the dates which we have done. And
You have done?
Yes, sir.
Did you go through that 16-week scan and look at the HC?
16 weeks scan, we check with the gestation age from the 16 week scans.
Yeah, it's a good idea to look at the HC, that image. Okay. And you also told that she had a 20-week scan, right?
Yes, sir.
So 16 weeks measurement, you put it in the graph, 20 weeks measurement, you put it in the graph, and see that they follow a growth velocity. See that at 16 weeks it was maintaining and 20 weeks it was maintaining. That confirms the gestational age. So always have a look at the image. Try to have a look at the image. It's easy. The HC you should always identify. CRL you should always identify. Okay, then you have confirmed the dates then.
We have to do an ultrasound examination and see for the parameters, sir.
Okay, let me ask you here. can you make a diagnosis of IUGR without ultrasound?
No,
No,
sir.
sir.
No,
No, sir.
Ultrasound
only
is necessary. always.
Can you make a diagnosis of SGA without
Yes.
ultrasound?
SGA can be
Yes.
made.
So there lies the answer. Whereas an SGA is a non-specific diagnosis, whereas an IUGR is a specific diagnosis. Okay. You need ultrasound to tell that the smallness is due to placenta. Okay, we'll see how. Okay. So in the ultrasound, what are you going to look for?
We look for the
parameters.
estimated fetal weight.
Okay.
Patient has come like early, we can look for the gross anomalies also if it was missed anything. So any anomaly as such for the baby.
Yeah, at 36 weeks also you can look for gross anomalies. The term gross may indicate the ones which are very lethal. Except for limbs, you can see most of the things at 36 weeks. Then
Dopplers we will see for, sir. At 36 weeks, we'll see for umbilical artery and MCA, middle cerebral artery PA, and this is cerebral placental ratio.
what do you mean by umbilical artery Doppler? What does it aim to find out?
Impedance to the flow to the fetus at the placental level is seen, sir. Resistance at the placenta.
So impedance to flow in the umbilical artery, which indicates resistance in the.
Blood flow to the baby at the level of placenta.
No, it's not blood flow to the baby. The umbilical artery goes from baby to.
Placenta.
To the placenta.
Yeah, it's
Placenta.
fetus to placenta. So if there is an impedance, it's impedance, the resistance is there in.
The flow from the fetus to the placenta.
The resistance is there in the placenta. The impedance represents downstream. What is downstream? Downstream is placenta. So if the placenta is giving a lot of resistance, that means it has got some kind of a disease, correct? It's not healthy.
Yes, sir.
It's getting obliterated. The circuit is getting obliterated. So umbilical artery represents placental disease.
Yes, sir.
So in indirectly what you are doing by doing an umbilical artery is you are asking the question, is the placenta healthy or is it showing evidence of disease? When will it show evidence of disease? Through an umbilical artery. How much placenta has to be diseased if you want to get it shown on the umbilical artery? What percentage of placenta should be out?
Around 50% should be damaged to get an increased resistance in the umbilical artery, and when there is absent flow around interstitial, around 70% is damaged.
Okay, we can keep it a little bit less than that. About 30 to 40 will start showing a higher resistance, and by 50 you will get absent. By 70 you will get reversed. So there is some correlation. Okay, you said you wanted, very good. You said you wanted to go for middle cerebral artery. What are you looking for and what does it indicate?
Mild placental insufficiency, especially in late onset FGR, will be missed if we are seeing only umbilical artery PAs. So we have to see MCA-PA where...
the answer that you are giving is, why should you look for MCA? But the question was, what does it represent?
Increase in the dilatation of the vessel.
Manoj, you are not clear. Can you say that again one more time?
Increase in the vascular dilatation in the middle cerebral artery.
Yes. What does it indicate?
Brain sparing
effect.
Can be more specific? More specific? What exactly happened?
Placental disease, the nutrients and like oxygen oxidation of the blood will be less. So the fetus will direct the circulation more to the brain for the brain growth. So there will be...
Okay, so let's compare the terms, because if you start using different terms, then it becomes confusing. In the placenta, in the umbilical artery, you look for impedance. If there is placental disease, the impedance is going to go up or down. Tell me, up or down?
Impedance will be increased.
Oh, okay, so I'll keep it as up. You will use simple terms.
Okay.
Now, in the brain, you have told that if the baby is suffering hypoxia because the placenta is not giving enough oxygen, the baby will try to increase more flow to the blood and there will be brain sparing effect. Okay, now come back to the impedance term. You're looking at MCA, you're looking at the impedance in MCA. If there is hypoxia in the baby, is the MCA impedance going to go up or down? Impedance.
Impedance will go down.
Go down. Excellent. So MCA represents what? Placenta represents placental disease. MCA represents
The baby.
Baby.
The fetal status.
Fetal status.
fetal adaptation. Excellent. So we have a mechanism to look at placental disease. We have a mechanism to look at fetal adaptation. Fetal adaptation. Do you think placental disease and adaptation have a continuity, a correlation? Do you think they go hand in hand?
Not
Say
necessarily.
yes or no. Yes. Say yes. It goes in hand in hand. It's only a matter of time before it manifests fully, but there is always a good correlation. Okay. Therefore, you can use one more tool. What is that? Yeah.
Cerebroplacental ratio.
Correct. A subtle change here and a subtle change there. You can amplify it by looking at the cerebroplacental ratio. What is that? Cerebroplacental ratio.
It's a ratio between the flow to the brain and the flow to the through the umbilical artery.
Flow or impedance? Impedance. So what is the formula?
MCAPI divided by umbilical artery PI.
MCAPI divided by umbilical artery PI. PI is an impedance parameter. Okay, that much if you understand, that's okay. Now, when the resistance increases in the placenta, what happens to this equation? The denominator changes how?
Denominator increases.
Increases. Very good. When the baby adapts, what happens to the numerator?
Numerator reduces.
Decreases. So in essence, in all variations, at all stages of this spectrum, the value keeps going down. Either the denominator will increase or the numerator will decrease, or both can happen. And in essence, the CPR, the index, decreases. Yeah. So a low CPR is an indicator of both sometimes or one of them sometimes. Okay. So you need to take it into consideration along with umbilical and MCA. You got it?
Yes, sir.
So standalone, we should not look at it. We should take into account other things also. Anything you want to add here, Sashi?
Yeah, we said estimated fetal weight and Doppler. So though it is a straightforward case of FGR also, but you should look at the placenta and the amniotic fluid volume also before you go for Doppler. And these measurements are dependent on performance. So even biometry, when you take biometry, you have to use the recommended landmarks, because you're going to use these charts. If it is error prone, especially if you are very casual in taking these measurements, it will be error prone. So we have to give utmost importance while taking the measurements, because we are going to define SGR, FGR based on that first. Second thing, look at the placenta and Leica also. Though maybe indirectly give us some clue, it's also important for management purpose.
Yeah. Okay. Now, Sashi has brought the question of Leica. Tell me, guys, how can you estimate Leica apart from clinical? Yeah, apart from clinical, where we palpate and we see a column that can be displaced. In ultrasound, what all methods that we can estimate Leica? Do you have any idea?
And amniotic fluid index and a single vertical pocket.
And there's the third one. Subjective assessment. Very important. Okay. Now, when you listen, if you are listening to me carefully, I use the word estimate the Leica. Okay. In reality, we cannot measure the exact quantity. Okay. Now, of the three, which has the highest false positive to diagnose fetal compromise? False positive, that is unnecessarily you will be raising alarm bells and intervening.
Amniotic fluid index.
Yes, amniotic fluid index, very correct. If you use AFI or single deepest pool, you will not miss the compromised fetus very much differently. But if you use AFI, you will be inducing or doing section for presumed fetal compromise much more than if you had used an SDP. So in all the assessment of amniotic fluid, SDP is the better one. Of course, it should match with your subjective assessment. Okay, subjective assessment is a little bit technical. We'll take it later. Now, as Sashi told, you will look into biometry first. You will have a look at the placenta directly in ultrasound, and then you will look into the Leica. And anything else before you go to Doppler? What are the components of biophysical profile?
Tone, gross body movement.
Yes.
Breathing.
Yes.
Amniotic fluid index and NST non-test.
Is it amniotic fluid index?
Amniotic fluid volumes.
No, volume cannot be found out. It's DVP, deepest vertical pocket. Okay. Tone, breathing movement, GBM, and reactive heart. Okay. So at least you should look for the fetal movements, and then only you should proceed to the Dopplers. Okay. Now in the biometry, how are you going to look at the biometry? How are you going to see the biometry and look at it?
Plain, sir.
Plain.
You didn't understand the question. So what parameters are important in the biometry?
The
Abdominal
biparatal diameter, head circumference, abdominal circumference, and femur length.
So they constitute biometry. What are important inside that?
Abdominal circumference is the most important one.
Yes, along with EFW. But the most sensitive to placental problem is abdominal circumference. Okay. Not only should you see today's biometry when you are going to do the scan, but you should plot the previous biometry at 20 weeks and see what is called
Interval
growth velocity. Okay, so for that you need to chart it on a published charts. Mostly we will use Hadlock is fine, intergrowth is fine, WHO chart fine. All are fine when it comes to finding out the growth velocity. It doesn't matter. Okay. Okay, so in this case, let me give you the findings of the ultrasound. The estimated fetal weight falls at 5th centile. The growth velocity chart shows there is a drop in growth velocity of the abdominal circumference and the EFW by about 15 centiles, and the MCA is on the 3rd centile. Umbilical artery is fine. CPR is at the 4th centile. What do you make out of these numbers?
Late onset.
There is fetal growth restriction.
How? Tell me, why did you make that conclusion?
The estimated fetal weight is at the 5th centile, along with the draw in the centile chart, as in the growth chart, the curve is showing falling over the quartiles. And
Yes.
MCAPI is also less than the 3rd centile.
Okay. So I'm going to put like this. Okay. Then. So there are 3 clinic essentials to make a diagnosis. Do you know that in FGR?
Yes, sir.
Tell me.
In late onset FGR, estimated fetal weight.
No, I didn't ask you about late and early. 3 essentials to make a diagnosis of FGR. The first should be, they should be smallness in size. Do we have it here?
Yes, sir.
The
Yes, sir.
second should be, there should be evidence of placental disease. Do we have it here?
Yes, sir.
Where? Which one?
MCPI.
MCPI.
No.
Just now we discussed MCA represents what?
It is 4%.
Yeah, MCA represents what? Placenta or something else?
Fetal adaptation.
Fetal adaptation. Okay, it's an indirect, but it represents fetal adaptation. So what? Anything to represent placenta? Yeah, one of that which we didn't discuss is uterine artery, impedance in the uterine artery. Okay, many times the placenta may not show impedance, but the uterine artery will show abnormal impedance. That can also be taken as an indicator of placental disease. In either case, I told you one more clue. The AC fell, the growth velocity of the abdominal circumference fell, but the other things didn't fall that much. Preferential lag in abdominal circumference is also an indicator of placental problem. So 3 things: smallness in size, evidence for placental disease, fetal adaptation. Yeah, 3 things. You don't have to have all 3, but all 3 will be there in some way. You should have at least 2 to make a diagnosis of
Fetal growth restriction.
FGR, which is a specific pathological problem, not SGA. Okay, so smallness in size, placental disease,
Adaptation, fetal
adaptation. Excellent. So smallness, disease, adaptation. So we should seek evidence for all the 3. Then only will there. Okay, now what type of FGR it is? You have been dying to tell me that. Tell me.
late onset.
We will it will take another time to differentiate, but just assume that after 32 weeks is an arbitrary time point that is given in the Delphi consensus. As long as growth restriction happens on the background of a normal placental impedance, that will behave like a late onset FGR. Do you understand? That means the umbilical PI is always within normal range, but there is FGR going on. That is going to behave as a late FGR. What is the danger between danger in late FGR?
Diagnosis is difficult.
Okay, we just made it simple, but what is the danger? Because the umbilical artery PA is normal, the red flag won't be raised. Okay, now this is the baby that is used to a good oxygen supply from the placenta, and now the placenta is faltering at a later stage. Okay, so there is a higher risk of stillbirth, which will go as unexplained stillbirth. So the danger is hidden mortality. Whereas in early FGR, the danger is all the problems of prematurity, because you'll be forced to deliver early. Okay, so your case is late FGR. Of course, she's come to 36 weeks. So it has to be late FGR only. How will you manage? The diagnosis is late FGR, it is 36 weeks and 6 days.
Based on her Doppler findings and ultrasound.
I gave you the Doppler findings.
She belongs to stage 1 of like fetal growth restrictions. So at 37, after 37 weeks, we can offer her labor induction.
We can do it.
Induce. Okay. Sashi, do you want to ask about the intrapartum management? They're going to induce tomorrow.
Okay. So now, tell me, how do you induce? I mean, you want to induce at 37 weeks or 38 weeks? This is late onset FGR. There is a
37.
Okay, but not later than 38 weeks. 37 to 38, not later than, definitely. Already there is a cerebral adaptation is there. So fetal, not later than 38 weeks. So what are the prerequisites for induction?
We have to verify the dates. Like
already done.
Confirm our diagnosis, verify it, check the pelvis. And C for the bishops.
Bishops, sir.
Okay. So which mode of induction you will use?
We don't
So
use
bishop score is less 4. Bishop is
Mechanical
4.
Mechanical mode of induction, ma'am.
Pharmacological methods are contraindicated.
No,
No,
ma'am.
they're not-
Pharmacological
not-
methods can be
not
used.
content.
Okay. Either you can use mechanical pharmacology as long as it is stage 1 FGR. Okay. So what are the intrapartum concerns? So we are inducing with Foley, then probably she's going to labor. What are the intrapartum concerns?
Increase
Chances of
fetal distress. Increase
fetal
fetal distress
distress
during
will be there.
intrapartum period.
because this baby cannot tolerate even single little stress also, so it can manifest as pathological CTG. So more chances are.
Operative interference will be more intrapartum.
If the Likert is also less, the risk of the magnitude of fetal distress, fetal compromise will be more. If CPR with a low MCAPA, the risk of intrapartum fetal distress is high. Okay. What are the neonatal complications? Early neonatal problems.
Hypoglycemia,
Hypoglycemia, hypothermia, increased risk of early onset sepsis.
Okay.
Yeah.
Hypocalcemia, hyponatremia, anemia, and polycythemia also, thrombocytopenia. So all complications are there. Late onset of disease, adulthood diseases.
cognitive,
Are they at increased risk?
Cardiovascular diseases, obesity,
Hypertension.
hyperlipidemia, and all are at increased risk.
hyperlipidemia, cognitive behavior also.
Okay. Suppose if the Doppler is normal. So already he gave a rough, appropriate some Doppler measurement, right? Suppose if the Doppler is normal, only the estimated fetal weight is 5th centile and abdominal circumference is 3rd centile or 2.5 centile. But the CPR is normal. MCAPA is normal. So what do you do? 36 plus
Should
6.
be induced at 37 to 38 weeks.
So if there is a severe smallness, probably we will not wait beyond 38 weeks. But if it is only SGA, that is Doppler is normal, but between more than 2.5 10 centile, maybe we can wait till 39 weeks. Otherwise, one of the component of FGR is there. Generally, it's better to deliver by 38 weeks. Okay.
Yes.
Okay.
So regarding that severe
Sir, sorry to
smallness,
interrupt. 5 more minutes, sir.
we are winding up. So see, I just have that one clarification about severe smallness. When we have severe smallness and we do not have evidence of placental disease or fetal adaptation, the outcome, if you don't intervene or intervene, we don't have, but we know that the outcome is going to be little bit poor. Now here you need to be little bit careful. You need to warn the parents that the baby is small, but we don't know why it's small, and we need to evaluate postnatally. You will find that in this subset, that is severe small, no evidence of with that severity. For example, like Sashi told, it's 3rd centile, 2.5 centile. With that severity, we expect some clue from the placenta. When you don't get it, then the risk of intrinsic problem to the fetus. For example, there are several monogenic disorders and some chromosomal disorders which may not manifest as obvious defects. Those intrinsic problems, which in the postnatal life, the neonatologists will call as failure to thrive. So those problems can be present up to 20 to 30%. That's a large number. So we need to forewarn the parents that we need to evaluate the baby after birth to know what is going on. At present, we don't know why it is small. So you need to tell that. And that's the reason why the outcome is poor, even in the absence of Dopplers. So we'll quickly wind up. Best obstetric estimate, we reviewed that the importance of knowing the gestational age for sure, that's for all, and most importantly for diagnosing FGR, but for all. Then we understood what are the criteria for diagnosing fetal growth restriction, not just early or late, okay? For all fetal growth restriction, these 3 criteria. Based on the umbilical artery PI, you can put it as early or late, but that's essentially old wine in a new bottle. Then when to deliver a late FGR and when to deliver even if there is no Doppler abnormality.